Hello friends, let's start our discussion with the tests of hearing. Alright, so let's come to the tuning fork test. Now the first question from the tuning fork test. Which is the most commonly used tuning fork for testing hearing? Answer is 512 Hz tuning fork. Okay, so if we get a question, you see 128, 256, 512, 1024. Which tuning fork we will not use for testing hearing? So answer over here is 128 Hz. This tuning fork is not used for testing hearing. Why? Because it has a lot of bone vibration. For the same reason, this tuning fork is used in neurologic examination. Okay, because it produces bone vibration, so it is used to check bone vibration and position sense. Right? But 128 is not used for testing hearing because the patient will feel the sound and he will not hear the sound. Okay, so he'll feel it like a vibration. So we don't use 128 Hz for testing hearing. We use 256, 512, 1024. All right. So the first tuning fork test is the Rennie's test. What do we do in Rennie's test? In Rennie's test, we take a tuning fork and vibrate the tuning fork, put the tuning fork near the EAC. Right? So we put this tuning fork near the EAC. Now what happens? The sound from the tuning fork through the air goes inside the EAC. Okay? Sound reaches the tympanic membrane. Tympanic membrane transfers the sound to the middle ear. The middle ear gives the sound to the inner ear. We call this as air conduction. Alright, so we call it as air conduction. Now what happens? You take the same tuning fork, vibrate the tuning fork and put it on your mastoid bone. Put the tuning fork on the mastoid bone. Right? So now when you put on the mastoid bone, now what happens? The tuning fork gives the sound to the bone and the bone transfers it directly to the cochlea. Okay, so the sound goes directly to the cochlea. This is known as bone conduction. Now, which is going to be more? Air conduction or bone conduction? See, air conduction, the sound is going through air to external ear, then to middle ear, then to inner ear. Bone conduction, the sound is going directly to the inner ear. Okay, so as we have said in the physiology, when the sound goes from external ear to middle ear, there is a amplification. There is an amplification of sound. How many times? 22 times. Okay. So therefore, air conduction is always more than bone conduction. Okay. The air conduction, the sound goes through middle ear. So the sound gets amplified before reaching the inner ear. So air conduction is always more than bone conduction. This is known as Rennie's positive. This is known as Rennie's positive. Positive Rennie's is seen in normal ear. Positive Rennie's is seen in normal ear. Okay, now let's say patient's external auditory canal is blocked. So EAC is blocked. Or let's say the tympanic membrane is perforated. It is having a perforation. Or let's say the ossicles are broken. There is a ossicular discontinuity. Now what happens in this case? What happens in this case? The air conduction is not able to take place. Okay, so the air conduction is not able to take place. Now what happens? Bone conduction becomes more than air conduction. Okay, so now the bone conduction becomes more than air conduction. This is known as Rennie's negative, seen in conductive hearing loss. Seen in conductive hearing loss. Right? So bone conduction becomes more than air conduction. Rennie's is negative, known as conductive hearing loss. Right? So now which diseases have conductive hearing loss? Very simple, very easy to remember. Which conditions will have conductive hearing loss? Those conditions in which air conduction is affected but bone conduction is not affected. So which conditions are those? Diseases of external ear and middle ear. Okay, diseases of external ear and middle ear, they present with conductive hearing loss because the bone conduction directly reaches the inner ear. It bypasses external ear and middle ear. So diseases of external ear, middle ear will not affect bone conduction. They only affect ear conduction. So remember, all diseases of external ear and middle ear, they cause conductive hearing loss. Okay, what is the second type of hearing loss? The second type of hearing loss is sensory neural hearing loss. Sensory neural hearing loss. Sensory neural hearing loss. So as you see over here, the name suggests you everything. Sensory and neural. Two parts. Sensory and neural. Okay, so sensory part is the sensory cochlea, organ of Corti, right? Neural is a neural pathway, right? So sensory neural hearing loss, so name itself tells you the problem is in the cochlea, that is the sensory part, or in the neural pathway, that is in the neural path. Okay, so sensory neural hearing loss. Now what happens? You give the sound through air conduction. Now when you give the sound through air conduction, what happens? The sound goes to the external ear. The sound goes to the external ear, then middle ear. Now what happens in the middle ear? The sound gets amplified. Okay, then it reaches the inner ear where it reduces. Now you do the bone conduction. When you do the bone conduction, the sound goes directly to the inner ear where it reduces. Okay, so the sound is getting reduced in both air conduction and bone conduction. But which is more? Which is more, air conduction or bone conduction? So now you see over here, the air conduction, the sound first goes to the external ear, then it goes to the middle ear. Middle ear, there is an amplification. And then it goes to the inner ear where there is reduction. So before reducing, the sound gets amplified. So therefore, air conduction is more than bone conduction. Okay. So again, once again, Renes is positive. Okay. So once again, Renes is positive. That means positive Renes is seen in normal ear and sensory neural hearing loss. Right? Positive Renes is seen in normal ear and sensory neural hearing loss. Whereas negative Renes is seen in conductive hearing loss. Right? Okay. I have a patient. This patient comes to me with a dead ear. With a dead ear. So what do I mean by dead ear? Dead ear means no working. No working. Dead ear. Okay. So you can define dead ear as severe or profound sensory neural hearing loss. Severe or profound sensory neural hearing loss, dead ear. Right? No hearing at all. So now this patient comes to us with severe or profound sensory neural hearing loss. Right? So now what I do is I do the air conduction. No sound. I send the sound through air conduction. No sound. So now we do the bone conduction. So now when we do the bone conduction, this ear no sound. But you see, this ear of the patient is normal. The other ear is normal. So what happens? So when you give a sound from here on the mastoid through the bone conduction, it vibrates the whole skull. It vibrates the whole skull. So what happens? The sound from here goes to the other side cochlea. The other side cochlea picks up the sound. And the patient is able to hear. Patient is now able to hear. Now, patient bone conduction is able to hear. And the patient thinks that you have put the tuning fork here, so he is hearing from this ear. He is hearing from right ear. Okay. So this bone conduction becomes more than ear conduction. This is known as false negative Renes. False negative Renes. Okay. Why false negative? Because the patient is picking up bone conduction from the other ear. Okay. So this is known as false negative Renes test seen in unilateral severe or profound sensory neural hearing loss. Remember, the other ear has to be normal. Okay. So it is seen in unilateral severe or profound sensory neural hearing loss or unilateral dead ear. Right? All right. Okay. So Then we come, you see, we have discussed in the beginning that there are three tuning forks that we can use. We can use 256, we can use 512 hertz, we can use 124 hertz, 1024 hertz. Alright, so in the beginning we have discussed that we can use three tuning fork for testing hearing. We can use, alright, in the beginning we have discussed that we can use three tuning fork for testing hearing. We can use 256 hertz, we can use 512 hertz, and we can use 1024 hertz tuning fork for testing hearing. So let's say we do the testing with all the three tuning forks. It comes negative, the range is negative with 256, it is positive with 512 and 1024. Now the conductive hearing loss is 20 to 30 decibels. Okay, if it is negative with 256 and 512, still positive with 1024, conductive hearing loss is 30 to 45 decibels. If it is negative with all the three tuning forks, conductive hearing loss is more than 45 decibels. Right? Okay, so this way we can grade the conductive hearing loss into three types with the help of these three tuning forks. Now, first question, which is the most sensitive tuning fork? Most sensitive tuning fork. So as you can see over here, 512 hertz. You see, this is the first to become negative even at 20 decibel hearing loss. So this is the most sensitive tuning fork. I can also ask a question, how much minimum conductive hearing loss is required to make any tuning fork negative? Any tuning fork test of RIN is negative. Okay, so answer will be 20 decibels conductive hearing losses. This is the minimum conductive hearing loss required to make any tuning fork negative. So suppose I ask a question, how much minimum conductive hearing loss is there? If 512 hertz is negative, then again the answer is 30 decibels. Right? So remember, this is how we can solve these questions. 256 is the most sensitive, but remember 512 hertz is the most commonly used. This is the most sensitive, but this is the most commonly used. Why don't we use 256? Again, the same reason, it also has some bone vibration in it. So patient at times feels the vibration rather than listening to the sound. Okay, so it can also have some false positive. So most reliable is 512 hertz. So this is the most commonly used tuning fork for testing it. Right? Okay. So then we come to the next tuning fork test, that is the Weber's test. So what we do in Weber's test? In Weber's test, what we do, we take a tuning fork, and as you can see in the photograph, we can put the tuning fork on the vertex, on the forehead, nasal bone, upper central nasals, anywhere in the midline. Now what happens? The sound, you have put the tuning fork over here. This tuning fork transfers the sound to the bone, and from the bone it goes to both the ears. So the sound is going to both the cochlea. The sound is going to both the cochlea through bone conduction. Okay, so let's say my both the cochlea are same. They are equal. My both ear are equal. Where will I hear the sound? Right side, left side, both ear, center. Now understand. Suppose there is a sound source over here. There is a sound source over here. This sound source gives sound. Sound reaches to both the ear. Same sound, same time, same intensity. Now what happens? Where will my brain localize the sound? The brain localizes the sound in the center. It tells me that the sound source in the center. Okay, now same way. We have put a tuning fork here on the forehead. Now sound goes to both the cochlea. Okay, sound goes to both the cochlea. Now what happens? Same sound, same time, same intensity. The brain localizes the sound in the center. Okay, so binaural hearing, we perceive this sound in the center. Okay, so a normal Weber's is in the center. A normal Weber's is in the center. Right. Okay, So now normal Weber's is in the center. Now you see, suppose, so we demarcate the Weber's normally like this. It is in the center, so you can mark it like this. It is in the center. Right? Okay, so this is a symbol that we can use. It is in the center. That means both sides it is going and it is in the center. Okay, so now let's say the Weber's, you see right side the patient is having sensory neural hearing loss. You're doing Weber's, right side the patient is having sensory neural hearing loss. Okay, so what happens? This side cochlea is less performing than the other side. This side cochlea is less performing, patient is having sensory neural hearing loss. So now what happens? You do the tuning fork test. This sound, this side, the cochlea is better performing, so it perceives more sound. Of course, the Weber goes towards the left side. Okay. So remember, Weber goes away from sensory neural hearing loss. It goes away from sensory neural hearing loss. All right. Let's say right side is having conductive hearing loss. Right is having conductive hearing loss. Now you are doing a tuning fork test. You have kept the tuning fork over here. In the midline, the sound is going through bone conduction to both the ear. The sound is going through bone conduction to both the ear. Now what happens? You see, both the ear bone conduction is same. Both the ear bone conduction is same. Okay. On the right side, there is a conductive hearing loss. The air conduction is reduced, but the bone conduction on both the side is same. Now you are giving the sound through both the sides through bone conduction. Both the cochlea are normal. This side air conduction is normal. This side air conduction is reduced. Now what happens? You see, there is some surround sound. There is some surround noise. This side patient has conductive hearing loss. So all the noise from the environment is not able to go into this cochlea. Whereas all the noise from this environment is going to this cochlea. So what happens? This cochlea is sitting in a noisy environment. Whereas this cochlea is sitting in a silent environment. You see, both cochlea are equally performing. But this cochlea is now sitting in a silent environment. This cochlea is sitting in a noisy environment. Obviously, we know we perceive sounds better, we hear better in a silent environment. So the Weber goes towards right ear. That means Weber goes towards conductive hearing loss. Okay. So remember, Weber goes away from sensory hearing loss, and it goes towards conductive hearing loss. So very simple. Weber's is one line. Normal Weber's is in the center. Normal is in the center, goes away from sensory hearing loss and towards conductive hearing loss. Clear? Please don't try to remember as diseased ear, non-diseased ear, better ear, worse ear. That will confuse you. Weber's is a very easy test. One single line, normal in the center, away from sensory hearing loss and towards conductive hearing loss. Okay, now, second thing. Whenever a question of tuning fork test comes to you in the exam, always check the Weber's first. Always check the Weber's first. That is the rule. Okay. Why? Let's say the question says Weber goes towards left ear. Very clear. So left can be conductive or right can be sensorineural. So you have immediately narrowed down to two options. Left conductive, right sensorineural. Right? Okay. So then you can go to the next test that is given in the question. But always check the Weber's first. Okay. Number 2 point, Weber's is much more sensitive than Rinne's. So we discussed Rinne's that minimum 20 decibels conductive hearing loss is required to make Rinne's test negative. Whereas Weber's, it shifts even if there is a 5 decibel change in hearing. So this is the most sensitive test. Even if there is a 5 decibel shift in hearing, the Weber's will shift. Right? Okay. Then we come to the next test. The next test of hearing is absolute bone conduction test, ABC. absolute bone conduction test, ABC. Okay, so to do this test, number one, first thing that we have to note down, the first thing is this is a comparison test. This is a comparison test between an examiner and a patient. It's a comparison test between examiner and a patient. Okay, second thing, the examiner is presumed to be normal. The examiner is presumed to be normal. Okay, third thing, you take a tuning fork, you put on the mastoid, and you take your finger and you close the EAC. You press this tragus, you press the tragus and you close the EAC. You stop all air conduction. Okay, so this is an absolute bone conduction, no air conduction involved. You press the tragus and you close the EAC. So this is the absolute bone conduction test, no air conduction involved. All right, so absolute bone conduction test, ABC. What you do, you take your tuning fork, vibrate the tuning fork, put it on the patient's mastoid. Put the tuning fork on the patient's mastoid. Now you take your finger at the same time and you press the tragus. So the patient has to inform you as soon as he stops hearing. So when the patient stops hearing, you immediately transfer the tuning fork on your own mastoid and you press the tragus of your own ear and you close your ears. Okay, so tragus has to be always pressed, the EAC has to be blocked always. Okay, so you transfer the tuning fork from the patient to the patient's mastoid to your own mastoid as soon as the patient stops hearing. Let's say you are still hearing. You are still hearing. That means patient's bone conduction is less than examiner. That means patient is having sensory neural hearing loss. Okay, let's say the patient, you place the tuning fork on the patient's mastoid and then patient informs you that he has stopped hearing. You transfer it to your own mastoid. You are also not able to hear any sound. So when the patient stops hearing, you transfer it to your own mastoid. You are also not able to hear. That means patient's bone conduction is equal to examiner bone conduction. That means patient is normal. Examiner is normal, patient is normal, right? Okay, so this is absolute bone conduction. This is absolute bone conduction test. Now suppose if I fail to close the EAC, if I do not close the EAC, then this absolute bone conduction test, it becomes Schwabeck's test. It becomes Schwabeck's test. So what is Schwabeck's test? What is Schwabeck's test? Okay, it's again a comparison test between patient and examiner. Number two, again examiner is assumed to be normal. So now you have not closed the EAC, you repeat the test, you take the tuning fork, place the tuning fork on the patient's mastoid. Patient stops hearing, you transfer it to yourself. So when you transfer it to yourself, you are still hearing. You are still hearing. That means patient bone conduction is less than examiner. Patient bone conduction less than examiner bone conduction. That means patient is having sensory hearing loss. Same like the previous test. Okay, next what you do is you take the tuning fork, you place on the patient's mastoid, patient stops hearing, you transfer it to yourself, you are also not able to hear. Now in case of Schwabeck's test, we repeat. Okay, we do it the reverse way. Now you take the tuning fork, you place it on your own mastoid. When you stop hearing, you transfer it to the patient. So patient says, I am also not able to hear. That means patient's bone conduction is equal to examiner bone conduction. That means patient is having normal hearing. Normal hearing. Okay, now let's say you take the tuning fork, you place it on the patient's mastoid. Patient has stopped hearing. You transfer it to yourself. You are also not able to hear it. Now we reverse the test. we take the tuning fork, we first place it on our own mastoid. Okay, so the examiner places on his own mastoid, and then when he stops hearing, he transfers the tuning fork to the patient's mastoid. Now what happens? Patient is still hearing. Now the patient bone conduction is more than examiner bone conduction. Now that doesn't mean the examiner is having sensory hearing loss. See, I told you in the beginning, examiner is always normal. Now what is the problem? Now the patient has conductive hearing loss. You see what has happened? Patient has conductive hearing loss. His ear conduction is not working. So he is not getting the surrounding noise. Whereas the examiner is getting all the surrounding noise. So cochlea is in a silent environment. Patient is able to hear better. The cochlea is able to hear the bone conduction sounds better than the examiner, because patient's cochlea is in a silent environment. So patient bone conduction more than examiner. Patient is having conductive hearing loss. Examiner is always normal. Right? So these are a few tuning fork tests that you have to commonly do. Okay. So let's come to some uncommon tuning fork tests that were used to be done earlier, that are not done these days very commonly, but they are sometimes asked as the MCQ questions. So let's do the test. Now before we go to do the test, let's do a Seagull speculum. Let's talk about Seagull speculum. So what is this Seagull speculum? So Seagull speculum, you can see this is a ear speculum. So this is a ear speculum. So you know this part is the ear speculum only, but this is a special ear speculum. This is connected to a magnification lens. So when we look through it, we see a magnified image of tympanic membrane. So this is used to see a magnified image of tympanic membrane. Okay, right? So M for magnification. Now you can see this Seagull speculum is also connected to a pneumatic bulb. So when you press the bulb, air will go in, it will move the tympanic membrane in and out. So you can also check the mobility of tympanic membrane. So M for mobility. Okay, suppose I put some drops, some powder medicine over here at the mouth of the speculum. I take my speculum inside and I press the bulb. Now what will happen? All the medicine is sprayed on the tympanic membrane, and if there is a perforation, on the middle ear mucosa. Right? So I can use this Seagull speculum for medication also. Okay, so magnification, mobility, medication. Right? It is used as two more places. One is Gillies test and one is Fischler test. We'll be studying about them sometime later. Okay, so this is M3GF. Okay, so you know, in my class there was a boy named Manish. So I made a mnemonic. Manish has 3 girlfriends. Okay, so Manish has 3 girlfriends. Okay, so that's the mnemonic over here. So you can use M for anything. Manish has 3 girlfriends. You can even say me have 3 girlfriends. So I have 3 girlfriends. That way also you can remember it. So M3GF, Seagull's speculum. Okay, right? So now we come to the next test, the next tuning fork test. This is the Bing test. All right. So then we come to the next test. The next test is the Bing test. Bing test. So what is Bing test? Bing test is a modification of Weber's test. It's a modification of Weber's test. What we do in Bing test, you take a tuning fork, vibrate the tuning fork, put it near the mastoid bone. Put it at the mastoid bone. Okay. So now what happened? The sound is going through bone conduction to the cochlea. Through bone conduction to the cochlea. Okay, now the patient informs you as soon as he stops hearing. So as soon as the patient stops hearing, you take your finger and you press the tragus. So you press the tragus, you occlude the AC. So now when you occlude the AC, you cut off the air conduction. Okay, so when you occlude the AC, you cut off the air conduction. Now what happens? So when you cut off the air conduction, immediately the cochlea goes into silent environment and is again able to perceive the tuning fork sound. Right? So if the patient is able to hear again, this is known as being positive. This is known as being positive. Positive is seen in normally. Or in case of sensory neural hearing loss. Right? Okay, suppose patient has conductive hearing loss. Patient has conductive hearing loss. Now what happens? As soon as the patient stops hearing, you press the tragus. But the patient's cochlea was already in a silent environment. Patient's cochlea was already in a silent environment. So what happens? There is no change. The cochlea is already in a silent environment. So whether you press the tragus or not does not make a big change to the patient. So this he will not start hearing once again. That is known as being negative. Being negative is seen in conductive hearing loss. Being negative is seen in conductive hearing loss. Okay, there is another test that is known as Gillies test. Gillies test. So what is done in Gillies test? Now, in a Gillies test, you take the tuning fork, place the tuning fork on the patient's mystoid. Okay, you place the tuning fork on the patient's mystoid. Now what you do is, in Gillies test, you take the Siegel speculum, put the speculum in the ear and press the. So when you press the bulb, you increase the pressure in the EAC. So tympanic membrane goes in, the pressure in the middle ear goes up. The pressure in the middle ear goes up. Now when the pressure in the middle ear goes up, what happens? The oval window, stapes footplate and the secondary tympanic membrane at round window, both of them are being pushed in. Okay, so both of them are being pushed in, what happens? So when they are being pushed in, the fluid inside is not able to vibrate. The fluid inside is not able to vibrate, the mobility of the membranes decreases. Now you see the bone conduction, the sound is going directly from the mastoid bone to the cochlea. You have put the tuning fork over here. So this sound is going to the cochlea directly. Now you have raised the pressure. The movement decreases. The movement of the fluid decreases. The movement of the membrane decreases. This sound perception also decreases. So in Gillies test, you increase the pressure. Now what happens? Immediately the loudness of the sound, it decreases. This is seen in normal ear. Also in sensorineural hearing loss. Okay, now we have a disease. This is known as otosclerosis. Okay, so this is the disease of conductive hearing loss. So what happens in otosclerosis? In otosclerosis, the stapes bone is fixed. Now what happens? The sound from the external ear goes to the middle ear. Okay, sorry, the pressure. So what happens in otosclerosis? When you press the bulb, the pressure from the external ear goes to the middle ear. But between the middle ear and the inner ear, the stapes footplate is fixed. It is fixed by bone. So now it is not transferring any pressure to inside, to the inner ear. So there is no change in loudness. Okay. So in otosclerosis, there is no change in loudness. This Gillies test was earlier done to detect otosclerosis. Okay. So this was earlier done to detect otosclerosis. Right. Okay. So these were the few tuning fork tests. So earlier we used to do some tuning fork test for malingering. So we don't do them nowadays. So, but we used to do them earlier. We should know at least the name of these tuning fork tests. So malingering, the commonly asked tests are Shimane-Moose test. So Shimane-Moose test, Stenger's test, and number 3, Lombard test. So remember, Lombard test was used for bilateral malingering. So what is malingering? Malingering is, let's say 2 people had a fight. Now 2 people have a fight, one of them slaps the other one. So now the other one says, this person has slapped me, I have total loss in hearing. I cannot hear anything at all. My ear has become dead. Okay. So we know that this is not possible, that one slap can cause total sensory hearing loss. So we assume that the person is malingering. He is falsely saying that he is having hearing loss. So this is non-organic hearing loss. This is also known as non-organic hearing loss. Okay. So to find out whether the patient is lying or saying truth, we have to do a few tests. So we have the Shimane-Moose test, we have the Stenger's test and Lombard test. Okay. So these tests are now obsolete. We usually don't do them in the clinical practice. So this is just for mentioning the name, that these names you should remember for your exam. Right. Okay. So these were the tuning fork tests. And then let's come to the pure tone audiometry. Okay. So after the tuning fork test, alright. So after the tuning fork test, we come to the next test for hearing, that is the pure tone audiometry. So we come to the pure tone audiometry. So what do we do in this test? In this test, we try to determine the degree or the amount of hearing loss and the type of hearing loss. Okay, so pure tone audiometry helps us find out how much hearing loss a patient has and what type of hearing loss a patient has. Alright, so to understand this test, first understand what is pure tone audiometry. So pure tone. First thing, pure tone. What are we checking over here? We're checking the hearing with pure tones. Pure tones mean, look over here, we give the patient sound at 125, 250, 500, 1000, 2000, 4000, 8000. So we're giving the patient sound at individual frequencies. So these are tones used. Okay, these are click sound, they are tones used. We give the patient sound at individual frequencies at pure tones. There is no complex sounds used over here, no words used over here, only pure tones, single frequency sounds. Alright, so this is a pure tone audiometry. Now how we do this test? To do this test, first of all, we take a normal individual. We take a normal person and we give him sound at each of these individual frequencies, at each of these pure tones. How much sound? Sound equivalent to his hearing threshold. Okay, so we give each patient, we give this normal individual sound equivalent to his hearing threshold or auditory threshold. So auditory threshold. So hearing threshold or auditory threshold. So what does that mean? So this is the minimal amount of sound. This is the minimal intensity of sound. Okay, so remember, intensity is measured in decibel. So this line is the measure of intensity. Okay, so minimum intensity of sound at a particular frequency. At a particular frequency at which the patient starts hearing. Right? So this is the minimum intensity the patient requires to just start hearing. So below this intensity, patient will not hear. Right? So we take a normal individual and we find the hearing threshold of that normal individual at each of these frequencies. At each of these frequencies. Right? So we find the hearing threshold for all the different frequencies and we know each frequency has a different intensity, different hearing threshold. Now what we do is, for all of these frequencies, we know the hearing threshold. Now we mark it as 0. What we do? We mark it as 0. Right? So we mark the hearing threshold as 0. Right? Okay, so now remember one thing over here. This zero over here, zero does not mean zero. Zero does not means zero. Zero means when my audiometry machine shows zero, that means it is still giving sound. It is still giving sound. Okay, equal for a normal individual to just start hearing. Equal for a normal individual to just start hearing. So zero does not mean zero. Zero means normal. Okay, one more thing. Second thing that you have to remember, this zero value for each frequency is different. This zero value for each frequency is different. Okay, so remember this thing. Zero over here does not mean zero. Zero means normal. Okay, so you see, let's say the patient has hearing loss. The patient has a hearing loss. Comes to me, says, "Sir, I have hearing loss. Can you check how much hearing loss does I have?" So what I do, I give him sound at 125 hertz. How much sound? Zero. Patient is not able to hear. I increase the sound by 10 decibels. So I increase the intensity of sound. Patient is able to hear. I mark it over here. 250 hertz is not able to hear at 0, 10, 20 is able to hear. I mark it here. So I am arbitrarily choosing some values for you to explain the curve. Okay, so at 500 hertz, let's say he's not able to hear at 0. I increase it by 10, 20, 30, 40, let's say he's able to hear. So I mark it here. 1000 hertz, he's not able to hear at 0, 10, 20, 30, 40, 50. 50 is able to hear, I mark it at 50. 2000 hertz, again is able to hear only when I increase it to 50. Okay, 4000 hertz, let's say I increase it by 10, 20, 30, 30 is able to hear. So I mark it here. Okay, let's assume 8000 hertz is able to hear at 0 itself. Okay, so I have all these values. Now I connect these values. So when we connect these values, we get a curve. This curve is known as Peotron audiogram. So I have a Peotron audiogram. I have a curve. This is a hypothetical curve that we have just drawn. Now what does this curve means? What does this curve means? Remember, this curve does not mean hearing threshold of the patient. Why? So suppose I ask, what is the hearing threshold of the patient at 1000 hertz? So you'll say, answer 50. No. This is not the hearing threshold of the patient. 50 is not the hearing threshold. It is 50 decibels more than this value over here. But our audiometry machine is calibrated to show it as 0. We don't know the value of 0 over here. So if we don't know this value, we don't know this value. But we know that the difference between the 2 points is 50 decibels. That means 50 decibels more sound is required by the patient to hear like a normal individual. 50 decibels more sound is required by the patient to hear like a normal individual. So this is the hearing loss of the patient. This is the hearing loss of the patient. So remember, first thing, audiometry shows the Peotron audiometry. It gives you the amount of hearing loss of the. It gives us the amount of hearing loss. Right? Okay. So we can do this. We can do the audiometry by giving the sound through air conduction, and we can also do the audiometry by giving the sound through bone conduction. So we can find out about air conduction, we can find out about bone conduction. Okay, so before we go further, let's understand the symbols. So symbols, audiometry symbols are very important. Okay, so instead of keeping any photograph over here, I am drawing these symbols for you to understand. Okay, so let's draw an individual. So we have an individual over here, and we are going to do the testing for this individual, right? So we have to do the testing of the individual. So we are giving the sound. We are giving the sound to this individual. So we are giving the sound to this individual. Okay. So what are we going to do? We are going to learn the symbols that are used in audiometry. So symbols for air conduction, for bone conduction, for bone conduction with masking. So that I will tell you what is bone conduction with masking. So what first we do is we give the sound through headphones. Okay, so you see this is the right side, this is the left side of the patient. Okay, so first thing, R for R, right for red. So right side is marked with red. Right side is marked with red, left is marked with blue. So R for R, right for red, left for blue. Okay, so how do we remember the symbols? Now it's very easy. You see, in our country, in politics nowadays, there are two groups. We have the right wing, we have the left wing. Okay, so you know that today everybody knows the news. So we have the two wings, we have the right wing and we have the left wing. Okay, so we know right wing people are known as nationalists, left wing people are known as anti-nationalists. Okay, so right wings are known as nationalists, left are known as anti-nationalists. So we know left are bad for the country, so we give them a cross. We give them a cross. Right? So left side bone conduction is, left side air conduction is marked with a cross. Okay, so left side air conduction is marked with a cross. The air conduction curve is marked with a solid line always. Right? Okay, so left is marked with a cross, but the right wing people, or we gave the government to the right wing people 4 years back, and the right wing people, their performance till date is still 0. The performance till date is still 0. So we give them 0. We mark the right side with 0 or with circle. Again, the air conduction curve is a solid line. Right? Okay, let's come to the bone conduction. So bone conduction is marked with an arrow. The bone conduction is marked with an arrow pointing towards the side. Pointing towards the side, the bone conduction curve is a dotted line. The bone conduction curve is a dotted line. Similarly, on the other side, the bone conduction curve is a dotted line and the bone conduction is marked with a arrow pointing towards the left side. Right? Okay, so now you see sometimes we give the sound to the bone conduction. What happens? The sound is picked up by the other ear. The sound is picked up by the other ear. So now the other ear interferes in this ear hearing. Suppose I am doing the testing for right ear. The left ear is interfering in my right ear testing. So what I have to do? I have to make this ear busy. I have to make this ear busy. How do I make this ear busy? I give extra noise in it. I give noise in this ear so that I can check for my right ear. So this is known as masking. So what is masking? Masking is giving noise in the non-test ear. Giving noise in the non-test ear. Okay. So when we do masking, so instead of the arrowheads, we use brackets. So instead of the arrowhead, we use bracket. So similar direction, we use bracket. So again, the bone conduction curve is a dotted line, but now instead of the arrowheads, we use bracket. So that was for the left and this is for the right. Right? So these are the international symbols which are used to do Puritan audiometry, and we have to remember these symbols. Right? Okay. So before we go further, let's see the range of hearing loss. Range of hearing loss. How much is defined as a hearing loss? So when I say the range of hearing loss, this is the range of sensory neural hearing loss. Sensory neural hearing loss. And this range was given by Clark's in 1981. So this is the Clark's range or the Clark's classification. So remember, till 25 decibels, it is taken to be normal hearing. Till 25 decibels taken to be normal hearing. Now you can start adding 15 decibels to it. So you see, you add 15 till 40, 26 to 40 is mild. Again add 15, 41 to 55 is moderate. Again add 15, 56 to 70 is moderately severe. So you keep on adding 15 to it. Okay, so 40, 55, 70, and then you add 20. Then you add 20. So when you add 20, 71 to 90 is severe. So 91 onwards, so more than 90 to 91 onwards, it is profound hearing. More than 91 it is 90 or more than 90, 91 or more than 91 it is profound hearing loss. Right? So this is the Clark's classification or Clark's ranges of sensorineural hearing loss. Okay, but remember the MCQ question, recently WHO modified this classification. So this is a Clark's 1981 classification. The WHO recently modified this classification. So now we have a WHO classification. So what is a WHO classification? You see 0 to 25 once again normal. 0 to 25 normal and 26 to 40. So similar like previous, at 15, 26 to 40, it is mild hearing loss. Okay, now we add 20. So 41 to 60, 41 to 60 moderate, 61 to 80 severe. Remember, there is no moderately severe now. There is no category of moderately severe. Okay, and then more than 81. More than 81 is profound. So this is a repeat question. It has already been asked in the AIIMS exam. How much as per WHO classification? What is profound hearing loss? So as per WHO classification, now 81 and more than 81 decibels, this is profound sensory hearing loss. It was earlier 91 in Clark's classification. Right? Okay, so this is the hearing loss grades as per the recently described classification by WHO. Let's go over here. So what is this? So what is this? So this is a pure audiometry graph. You can see that, and you know that this is for the left side. Why color is blue? You can see the cross is for the air conduction of the left side. You can see the arrows of the left towards the left side. So these are the bone conduction. So both air conduction, bone conduction shown. Both are near zero. Both are near zero, less than 25. So what is this? This is a normal hearing. This is a normal hearing. Remember, zero is normal. Zero is normal. So both air conduction, bone conduction are at zero. That is normal. Okay. What is this? What this is? So again, left side, you can see the air conduction has come down. The air conduction has come down, whereas the bone conduction is still at zero. So bone conduction is normal, air conduction has reduced. So tame a disease where bone conduction remains same, air conduction reduces. Conductive hearing loss. Bone conduction remains normal, air conduction reduces. So this is conductive hearing loss. Now remember, whenever we do a pure tone audiometry for a conductive hearing loss, whenever we do a pure tone audiometry for a conductive hearing loss, you see there is a air bone gap. There is a gap between the air conduction curve and the bone conduction. This is known as air bone gap, or also known as AB gap. So whenever the patient has air bone gap or AB gap, that means patient has conductive hearing loss. There is a gap between air curve and bone curve, air conduction and bone conduction. So there is a AB gap. So AB gap means patient has conductive hearing loss. Okay, what do you see over here? What do you see over here? You see over here in this range, you see that both air conduction and bone conduction have come down. Both air conduction and bone conduction have come down. There is no AB gap. Please note, there is no AB gap. Both air conduction and bone conduction have come down. Okay, so when do they come down? They both come down in sensory neural hearing loss. So this is a sensory neural hearing loss. Both of them have come down. There is no gap between the two curves. This is a sensory neural hearing loss. Right? Now, this curve shown over here, this is a special type of sensory hearing loss. What is this special type? You see, there is a dip at 4000 Hertz. There is a dip in hearing at 4000 Hertz. This dip in hearing at 4000 Hertz, this is known as Boiler's notch. Okay, So a boiler's notch. So this is known as boiler's notch, right? So where do we see a boiler's notch? A boiler's notch is seen in noise induced hearing loss. So this is sensory hearing loss. This is sensory hearing loss. Okay, and sensory hearing loss. Okay, so then we come to this curve. What do we see in this curve? This is again of the left side. You can see the blue line. Okay, you can see that the air conduction, the bone conduction, both of them have come down. Now please notice there is no air bone gap. So a disease where both the air conduction and the bone conduction curve, they come down, but there is no air bone gap. There is no gap. Okay, so what is this? When both of them are affected, this is sensory neural hearing loss. What is this? This is sensory neural hearing loss. Okay, so now in this both of them are affected, right? Now this is a special type of sensory neural hearing loss. You can see there is a dip. There is a dip at 4000 hertz. There is this dip at 4000 hertz. This dip is known as boiler's notch. This dip is known as boiler's notch. Okay, this boiler's notch is seen in noise induced hearing loss. Okay, patient has maximum hearing loss at 4000 hertz. So this is known as boiler's notch, right? Seen in noise induced hearing loss. So this is a special type of sensory hearing loss known as noise induced hearing loss. So MCQ question, noise induced hearing loss. Number one, we have a boiler's notch at 4000 hertz. Number two, this hearing loss is maximum seen at 3000 hertz to 6000 hertz. So 3 to 6 with notch at 4, 3 to 6000 hertz, 3 to 6 kilohertz, right? 3000 hertz to 6000 hertz, right? Okay, so this is the range that is maximum affected by noise induced hearing loss. 3000 to 6000 hertz, maximum affected. Now another question is asked, which sound frequencies cause maximum noise induced hearing loss? So remember, this is a separate question. Which sound frequencies cause maximum noise induced hearing loss? Okay, so now the answer is 2 to 3000 hertz. 2 to 3000 hertz. These frequencies cause maximum noise induced hearing loss because they are maximum concentrated by the middle ear. They are maximum concentrated. Okay, so these are the frequencies which cause maximum noise induced hearing loss. Maximum noise induced hearing loss is seen in 3 to 6000 hertz. The dip is at 4000 hertz. Okay, next question. Which part of the inner ear is first to get affected? Which part of inner ear is first to get affected? Answer is stereocilia of outer hair cells. Okay, so we have the stereocilia of outer hair cells. So the next question is, which part of the inner ear is first to get affected? Which part of the inner ear is first to get affected? So answer is stereocilia of outer hair cells. Stereocilia of outer hair cells. They are the first to get affected in noise induced hearing loss. Okay, so the next question which is asked is, what test can we do? What test can we do to find out about this noise induced hearing loss even before it appears in audiometry? Answer is autoacoustic emission. Remember autoacoustic emissions? Autoacoustic emissions, they are the most sensitive test for outer hair cells. They are the most sensitive test. Okay, so we can do autoacoustic emissions. So they can also be used for finding out the noise induced hearing loss. Okay, so we'll talk more about it later. Let's go to the next chart over here. So what do we see over here? What do we see over here? So now, number one, we see that the air conduction curve has come down, right? The air conduction curve has come down. So you can see the air conduction curve has come down. The bone conduction curve has also come down. Okay, so they should have shown it dotted. So right. So the bone conduction curve has also come down. So it's a dotted line. So I'm converting it into a dotted line. Okay, so you see the bone conduction curve has also come down. Right. So air conduction has come down, the bone conduction has also come down, right? And now you see there is a air bone gap. There is a gap between the two. Okay, patient also has a air bone gap. So both of them have come down. The bone conduction has come down. That means there is a sensorineural loss, but there is a AB gap. That means patient has conductive hearing loss. So this is a mixed hearing. This is a mixed hearing loss. So that means patient has both sensorineural and conductive components. So with the help of these these previous examples, we have now seen that through audiometry we can find the amount of hearing loss and we can find the type of. Okay, both the things we can find out, right? Okay, so identify the cause of hearing loss. So let's solve this question. Identify the cause of hearing loss. So as you can see that different types of hearing loss are shown over here: mild, moderate, moderately severe. So we can see all this: mild, moderate, moderately severe, severe, profound. So this is as per the Clark's classification. The hearing loss is shown over here. So now let's come to the curve. Now first thing, both the curves are marked in black. So the color hint is not given to us. Okay, we know right is red, left is blue. Okay, but right is red, left is blue, but this is not given to us. So we have to now go to the symbols. So remember, left is wrong, so left is marked with a cross. Right people, we have given them 0, so right is marked with a circle. So you can see the right and the left, both air conduction curves are given to us. Both right and left air conduction curves are given to us. Now the bone conduction curves are not given to us. As we can see, there is no bone conduction curve given in this photograph. So when the bone conduction curve is not given, we can safely presume that they are overlapping the air conduction curve. That means they are overlapping the air conduction curve. That's why the examiner has not given them separately. There was no need. Okay, so if the bone conduction curve is not given to you, you have to always presume that there is no AB gap. There is no AB gap. They were overlapping the air conduction curve. Okay, so now we have both right side and left side air conduction curve. Bone conduction curve is not given, so it is overlapping. So that means both right side and left side, they have a dip over here. Both of them have a sensorineural hearing loss, and again the dip is maximum at 4000 Hertz. So this is a case of bilateral noise induced hearing loss. Okay, so this is a case of bilateral noise induced hearing loss, right? So remember, proton tells you the amount of hearing loss, it tells you the type of hearing loss. It can also sometimes indicate the cause of hearing loss. Not always, but sometimes it can indicate the cause of hearing loss, because some diseases, they have typical hearing loss. All right, right. Okay, and we have already talked that the maximum noise induced hearing loss, it first affects the stereocilia of outer hairs. They first affect the stereocilia of outer hair cells. Right. Okay. So remember the normal sound that we use, starting from 0 decibels, 30 decibels is the sound that when we are whispering. A normal conversation takes place in 45 to 60 decibel sound. This is the sound range for the normal conversation. Okay. By 85 or 90 decibel, this is very loud. So 45 to 60 is normal conversation, and 85, 90 it becomes very loud. Okay, by 120 it is painful and starts causing hearing loss. Right? Okay, now there is a question that comes in the exam. Maximum audible tolerance is. So now let's come to a question. Maximum audible tolerance is. So now this question is asked many times in the exam. Maximum audible tolerance. So what do we mean by this? Maximum amount a person can tolerate. Okay, so you see the answer is given in 6 hours, 8 hours, 6 hours, 8 hours. So obviously this value is important for a person who's working in an industry, a factory worker, right? Who has to go off a shift, and we know the normal shift is for 8 hours. The normal shift is of 8 hours, right? So 6 hours is out. So this audible tolerance, this must be dealing with, the factory worker. As we have seen, you see the value is not given in seconds or minutes, it is given in hours. So this value 8 hours is for a factory worker. A normal factory shift is of 8 hours. And the answer is 85 decibel for 8 hours. Okay, please note down the value is 85 decibel for 8 hours. Right? This is as per the Indian Factory Law, Indian Factory Act. So the Indian Factory Act was given in 1948. At the time of 1948, the value was 90 decibel for 8 hours. But later on in 1994, the government changed this value and it decreased 5 decibel, and now the current value is 85 decibel for 8 hours. This answer is given wrong in lot of MCQ books. Okay, in many theory books also. Please note down, as per the current value, as per the current guidelines of the Ministry of Labor, the value is 85 decibel for 8 hours. Right? Okay. Above 85 decibels for 8 hours, the government has suggested a 3 decibel exchange formula. 3 decibel exchange formula. What do we mean by 3 decibel exchange formula? The 3 decibel exchange formula is, you increase the sound by 3 decibels, you have to decrease the time by half. You have to decrease the time by half. Okay, so let's see this table given by the Ministry of Health. This is the table directly taken from the Ministry of Health website. So you can see 85 decibel for 8 hours. So suppose I increase from 85 to 88, the time has to be reduced to 4. Okay, 91 decibels, again 3 decibels, the time has to be reduced to 2 hours. 94 decibels, 1 hour, so and so forth. Right? So you have to see the maximum audible tolerance is 85 decibel for 8 hours for a person who's working 5 days a week. Okay, if he works more than this, he will have noise-induced hearing loss. Or otherwise, the worker has to use sound protection in the ears. Right? Okay. Let's come to the next test of hearing, that is the impedance audiometry. So this impedance audiometry consists of 2 parts. Number 1, we have the tympanometry, and number 2, we have the stapedial reflex or the acoustic reflex testing. Okay, so let's first start with the tympanometry. Okay, so what we do in tympanometry? In tympanometry, we put a probe in the ear. This probe gives sound. It gives sound. How much sound? It gives sound equivalent. It has an oscillator over here. This oscillator produces sound at 226 hertz. At 226 hertz, so it gives sound. The sound is the tympanic membrane. Tympanic membrane vibrates. So when the tympanic membrane vibrates, it gives the sound to the ossicles, to the malleus. Malleus gives it to incus. Incus gives it to the stapes. Right? Incus gives it to the stapes. Right? But we know some sound is also reflected back. How much sound is coming back? That depends upon the stiffness. Or the impedance. That depends upon the stiffness or the impedance of the tympanic membrane. If the tympanic membrane is impedant, it is stiff, it will give away all the sound. If the tympanic membrane is vibrating, it is compliant, then all the sound will go in. So it is giving some sound back, and this sound we can measure with the help of a very sensitive microphone. Right? Now, what we do is we put a pressure probe. With this pressure probe, we give pressure. We can increase or we can decrease the pressure in the ears. right? So we can increase or decrease the pressure in the EAC. Now let's say we start increasing the pressure. We start increasing the pressure. What happens to tympanic membrane? Tympanic membrane starts going in. Now we keep on increasing the pressure. Tympanic membrane keeps on going in. There comes a point when it is maximum stretch. It has maximum gone in. Whatever pressure you give, it has maximum gone. It cannot be stretched any further. So now whatever sound you gave, all this sound comes back. There is no vibration. All the sound comes back. Right? Okay. So now what we do is, instead of increasing the pressure, we start decreasing the pressure. Now again tympanic membrane starts coming out. You keep on decreasing the pressure, tympanic membrane keeps on coming out. There comes a point when it is maximum stretched out. Now whatever sound you give, again it comes back. Okay. So again, whatever sound you are giving, it comes back. So across a pressure gradient, we get a curve. Across a pressure gradient, we get a curve. This is known as A-type curve, seen in normal ear. A-type curve seen in normal ear. See, the maximum compliance or the maximum mobility of tympanic membrane is seen when you have not applied any pressure. If you increase the pressure, or we decrease the pressure, what happens? The mobility goes. So as we increase the pressure or we decrease the pressure, the mobility goes down. So this is known as A-type curve. A-type curve is seen in normal ear. Right? Okay. So now let's say we have a disease. Let's say we have a patient with a disease. In this disease, his stapes is fixed. Stapes is fixed. This is known as autosclerosis. Right? In this disease, the stapes is fixed. So this is known as autosclerosis. Now what happens? Stapes is fixed. Right? So because the stapes is fixed, the mobility of stapes goes down. Okay. So now the incus mobility goes down, the malleus mobility goes down. Right? So incus mobility goes down, malleus mobility goes down, tympanic membrane mobility also goes down. So what we see over here, the tympanic membrane maximum mobility or maximum compliance has come down. Right? So it has come down to this point. Now we start increasing the pressure. So when we increase the pressure, tympanic membrane starts going in, and very quickly it will come to a point it cannot go in any further. So no further mobility, all the sound waves, they automatically come back. Right? So now instead of increasing the pressure, you decrease the pressure. Right? So the stapes is fixed, you decrease the pressure, and what happens? Tympanic membrane starts coming out, okay, and very quickly it will become fixed, not able to move. All the sound, they come back. So now again across the pressure gradient, we get a curve like this. This is known as AS type of curve. Okay. S for stiffness. So you can remember it like this. S for stiffness. So now tympanic membrane is moving less, it is less compliant, it is more stiff. S for small curve. You can see the curve is now smaller. Okay. S for sclerosis. So as we have seen, it is seen in autosclerosis. So you see this is seen in autosclerosis where the stapes is fixed. It is also seen in tympanosclerosis. So what is tympanosclerosis? It is deposition of calcium on the tympanic membrane. So tympanic membrane becomes chalky white. So we have a chalky white tympanic membrane. it becomes chalky white. We have discussed this when we were discussing the color of tympanic membrane. So tympanic membrane becomes chalky white and it becomes thick, it becomes stiff. Right? So AS type of curve. All right. Okay. Now let's say the ossicular chain is broken. Right? So the ossicular chain is broken. Now what happens? You see, this ossicular chain is broken. So when the ossicular chain is broken, the mobility of tympanic membrane increases tremendously. Now it does not have to move all the ossicles, it does not have to move the fluid in the inner ear, so the mobility increases. Now what happens? Now what happens? You see, now mobility has increased many times. But if I increase the pressure, what will happen? If I increase the pressure, what will happen? Tympanic membrane starts going in, and after some time it goes in and gets fixed. All the sound that I give come back. Again all the sound is coming back. Okay, so now what I do is I start decreasing the pressure. Tympanic membrane starts coming out. After some time it is completely out, it is completely stretched. Whatever sound I give, it comes back. So across the pressure gradient, we got a curve like this. Maximum mobility of tympanic membrane is increased. Maximum mobility is increased. But as I increase the pressure or decrease the pressure, this mobility once again comes down. This is known as AD curve. This is known as AD curve. AD. D for discontinuity. D for discontinuity. There is a discontinuity in the curve. As you can see, they are meeting at some point quite superiorly. So they go and they meet some point very superiorly. Right? Okay. So AD, discontinuity in the curve. Number 2, discontinuity in the ossicles. So ossicular discontinuity. Ossicular discontinuity. D for decrease in stiffness. D for decrease in stiffness. D for dimeric. This I will explain later. D for dimeric. Right? Okay. Now let's say the middle ear is filled with fluid. The middle ear is filled with fluid. Now what will happen? So the middle ear is filled with fluid. This fluid is putting pressure on the tympanic membrane. Tympanic membrane is bulging outwards. Right? Now what happens? You give the sound comes back. Okay? All the sound comes back, tympanic membrane is not able to vibrate. You increase the pressure, again what happens? All the sound is still coming back, the sound is not able to go. You decrease the pressure, again tympanic membrane is not able to vibrate because of the fluid, again all the sound is coming back. Okay, so that means across a pressure gradient, we get a curve like this. This is known as B-type curve. B-type curve. This is known as B-type curve. B-type curve is seen in fluid in the middle ear. So remember, fluid is always flat. Fluid is always flat. So this is B-type curve. B-type curve seen in fluid in the middle ear. Okay, so fluid is flat, the curve is also flat. Right? Okay, so let's solve the last one. Let's say we have a retracted tympanic membrane. So there is a retracted tympanic membrane. Right? So this tympanic membrane is pulled in. Now what happens? So tympanic membrane is pulled in. Now what happens? We give some negative pressure. Outside we give some negative pressure. The tympanic membrane comes back to its normal position. So once the tympanic membrane comes to its normal position, what happens? Now it will vibrate normally. Okay. So what kind of curve we will get? We'll get a curve just like A. But remember, you have first given some negative pressure. You have given a negative pressure. So this curve looks like A, but it is centered around negative pressure. The peak is at negative pressure. This is known as C-type curve. C-type curve is seen in retracted tympanic membrane. It is seen in retracted tympanic membrane. Okay, so you see we have the 5 curves. A is normal. AS is S for stiffness, S for sclerosis. AD, D for discontinuity, T for diameric. Okay, B curve, fluid is flat. Fluid is flat. So B curve seen in fluid in the middle ear. We will discuss the conditions that have fluid. Okay, C is like this. So C, the tympanic membrane is also like this. Tympanic membrane is retracted. So C for retracted tympanic membrane. Right. So these are the 5 audiometry curves: A, AS, AD, B, and C. All right. Let's come to the second part of impedance audiometry. So what was the second part of impedance audiometry? The second part of impedance audiometry was stapedial reflex, also known as acoustic reflex. So this is the stapedial reflex or acoustic reflex, also known as middle ear muscles reflex, attenuation reflex, or auditory reflex. So many names for the same reflex, right? So many names for the same reflex, acoustic reflex. What is this reflex? What is this stapedial reflex? Right. Whenever a loud sound goes in the ear, whenever a loud sound goes in the ear, the stapedius muscle contracts. This stapedius muscle contracts. Okay. Remember, stapedius muscle supplied by which nerve? Facial nerve. So this muscle contracts. So when it contracts, what happens? It pulls the stapes back. It pulls the stapes back, so stapes is not able to vibrate. So vibration of stapes goes down. So when the vibration of stapes goes down, the sound is further not able to go into the inner ear. The sound is not able to go into the inner ear. Inner ear is protected from noise trauma. Inner ear is protected from noise trauma, acoustic trauma. Right? So the inner ear is protected from noise trauma or acoustic trauma. Right? So this is known as acoustic reflex or stapedial reflex or auditory reflex. It protects our inner ear cochlea from noise-induced hearing loss. Right? So whenever there is a loud sound, stapedius muscle contracts, stops the stapes from vibrating, stops the sound from going into the cochlea, and prevents the cochlea from noise-induced hearing loss. Alright, so this is our stapedial reflex. So you see what happens? There is a sound in the middle ear. This sound goes to the cochlea. The sound goes to the cochlea. Okay, so now what happens? From the cochlea, the sound goes to the cochlear nucleus, to the cochlear nerve, 8th nerve. Right? From the cochlear nucleus, remember, from the cochlear nucleus, the sound goes to the superior olivary complex. Okay. From the superior olivary complex, you see it's a loud signal. It's a loud signal. So what happens? So the superior olivary complex, the sound goes to the brain. The sound goes to the brain, but some reflex goes and stimulates the same side facial motor nucleus. Okay, so the facial motor nucleus is stimulated, the facial nerve is stimulated, it goes into the middle ear and stimulates the stapedial muscle. The stapedial muscle contracts, stops the sound in the middle ear. Okay, but remember, from cochlear nucleus, there is a crossover of sound. Okay, so this what I have just told you is the ipsilateral stapedial reflex. But from the cochlear nucleus, there is a crossover of sound. Remember, at the superior olivary complex, the crossover of sound takes place. So now the opposite side superior olivary complex is stimulated, and it of course gives the sound up to the brain, but it also stimulates the contralateral facial motor nucleus. Okay, so the contralateral facial nerve is stimulated, and we have a contralateral stapedial reflex. We have a contralateral stapedial reflex. That means if I give a sound in one ear, both the stapedial muscle are contracted. Both, I'll get a ipsilateral and a contralateral reflex. Both the stapedial muscle are contracted at the same time. Okay, so this is known as stapedial reflex or acoustic reflex. Okay, now let's come back to this apparatus. So let's come back to this apparatus. So when we come back to this apparatus, what do we see? What do we see? Okay, we see we have this apparatus. Now what we do is we give the sound, we give a loud sound. Loud sound means we give a sound 85 decibels above the hearing threshold. So we give a loud sound. So when we give a loud sound, what happens? When we give a loud sound, what happens? The loud sound goes to the middle ear, tympanic membrane, and middle ear. Immediately the stapedial muscle contracts. The stapedial muscle contracts. So when the stapedial muscle contracts, the stapes is fixed, incus mobility goes down, malleus mobility goes down, tympanic membrane gets fixed. It is not moving. Stiffness of tympanic membrane increases. Okay, so what happened? You give a loud sound. You give a loud sound. Immediately the stapedial muscle contracts, stiffness of tympanic membrane increases. So stiffness of tympanic membrane increases, more sound is reflected back. More sound is coming back. So you can check the stiffness of tympanic membrane, whether it has increased or not. If it has increased, the stapedial reflex is present. So now what you can do? You can give the sound in the other ear and you can check for response in this ear. Now this is known as contralateral stapedial reflex. The sound is coming from the other side. So contralateral stapedial reflex is also present or not. So the same apparatus can be used to check for tympanometry curves and to check for stapedial reflex testing. Together they are known as impedance audiometry. So remember, impedance audiometry means tympanometry plus stapedial reflex test. Alright, so we have completed the basic tests of hearing. Now let's come to some special tests. So first understand, what all we can do in hearing assessment. Hearing assessment is of two types. There is a subjective assessment and there is a objective assessment. Okay, so what comes in subjective assessment? You see, when a child is born, from birth to a few months, let's say 6 months, from birth to 6 months. Okay, so now the child is very, very small in age. His understanding is very little. So we can just check for his behavior. All right. So now after 6 months, the child can be brought to give more responses by enforcing the signals by some visual clues, right? Okay, after that the child can be made to do the hearing assessment. So we're gonna study all of these. So these are all tests, just subjective tests. Okay, so let's go over here. You see, when the child is very, very small, from 6 months, from birth to 6 months. Okay, so we have a behavioral observation audiometry, BOA. Okay, BOA. So this is behavioral observation audiometry. So what we can do is we can clap, so we can see whether the child moves his head. Okay, so that gives us clues that whether the child is hearing or not. So this is behavioral observational audiometry. Now after 6 months, from 6-7 months to 3 years, the child can be this signal can be reinforced to child with the help of some visual clues. So suppose there's a TV screen in front of the child or on the side of the child, and whenever there is a sound comes from there, a cartoon character comes up. So the child is attracted to the cartoon character. So child knows if there is a sound, there is a cartoon character. So he will always look towards the sound. Also, he will always look towards the source of the sound. So this is known as visual reinforcement orientation audiometry. Right? After 3 years, the child can be made to play. Whenever the child listens to a click sound, he has to pick up an instrument and pick up a toy and put that toy in a basket. Okay, so this is play audiometry. So child is playing, so you can increase or decrease the intensity also, and you can check differentially whether the child is hearing or not. So this is play audiometry. That is done from 3 to 9 years. After 9 years, you see again this is play audiometry, and after 9 years we can do the normal current audiometry. So as as I was talking about, the subjective test. Subjective test means patient response is required. Okay, so subjective test, from birth to few months, we have to observe the responses. So what we are able to do is behavioral observation audiometry. Okay, after 6 months, we can condition those responses, right? So by visual reinforcement audiometry, we can condition those responses. Then we can request the child, okay, you go and keep a toy in the bucket every time you hear a signal. Okay, so right, and after 9 years, we can do the pure audiometry, right? Let's come to the objective test. So what are the objective tests? The objective tests are your BERA, ABR, that we have discussed, the autoacoustic emissions that also we have discussed earlier, the electrocochleography, acoustic reflex, and tympanometry, impedance audiometry. So all these are objective tests. That means they do not require the patient response, right? So they can also be used for malingering. Now the best objective test is BERA. This is the best test for malingering, right? Okay, so these are the objective tests. As I have already told you, to observe the response, we have behavioral observation audiometry. To condition, when we condition the response, is known as visual reinforcement observational audiometry. Then to request response, we can have a play audiometry in children, and we can have a pure audiometry in adults, right? Remember, we have to consider the individual's functional age, the mental age. That is important for us, not just his actual age. Okay, right? So now we come to some other special test for hearing. Okay, so number 1 is the speech audiometry. Speech audiometry. So this speech audiometry has 2 components. What are the 2 components? Number 1, we have the speech reception threshold. Okay, so now we all love cricket in India. So cricket, this is known as cricket crazy country. So the speech reception threshold, how we can remember it? We can remember it as SRT. What is SRT? SRT is, in cricket, SRT means Sachin Ramesh Tendulkar. Okay, so I call it as SRT score, the god of cricket, Sachin Ramesh Tendulkar. Okay, so this is the SRT score. Okay, so now we know the BCCI, it created a score that anyone who can hit more than 50% balls outside the boundary, we will keep that person in our cricket team. Okay, so they brought out a score, so that is known as SRT score, right? So anyone who can throw out 50% balls outside the boundary, okay, who can hit the 50% balls outside the boundary, that batsman will be kept in the cricket team. Okay, so that is your SRT, speech reception threshold. So what does the speech reception threshold means? This means that sounds are given. What sounds? Disyllabus speech sounds. Spondy words. These are known as spondy words. Okay, so spondy words means pin, ball, pen, cake, hardware. Okay, so you see playground. These are 2 syllabi, bisyllabi words. Each word has equal weightage. Okay, each word has equal stress. So these are bisyllabi word, and the individual has to identify all these words, at least 50% of these words correctly, right? So this is SRT score. Now there is a second score. Okay, this second score in speech audiometry is SDS score. All right, so this SDS score means speech discrimination score. This is speech discrimination score. Now what is checked in speech discrimination score? What is checked in speech discrimination score is phonetically balanced words. What is checked in speech discrimination score is phonetically balanced words like pin, tin, bin. So these are phonetically balanced words, right? Okay, and these words have to be identified 40 decibels above the SRT. So first we find the SRT. That means we find a person who can at least hit 50% of the balls outside the boundary. So he was taking in the cricket team. Now let's say this person comes to play after 40 overs. So who comes to play after 40 overs? Who comes to play after 40 hours? So we know who comes to play. Mahendra Singh Dhoni. Okay, MSD. Mahendra Singh Dhoni, he is the number one finisher of our team. So Mahendra Singh Dhoni comes to play after 40 overs. So we has the MSD score, MSDS. Okay, so we have the MSDS score, okay, or the Mahendra Singh Dhoni score. So this is the speech discrimination score. So what is done over there? This SDS, this speech discrimination score, that is above 40 decibels. So what does Mahendra Singh Dhoni said? He said, I will keep a person, I will send a person after 40 overs, the person who is capable of hitting all the balls outside the boundary. So after 40 overs, you don't need 50%, you need 100% balls to be hit outside the boundary. All right. So SDS means the speech discrimination score has to go 100%. All right. So this is known as PB max. So PB max. So max, from the max, I have taken the M. Okay. So Mahendra Singh Dhoni score or the SDS over here, this PB max has to reach 100%, 40 decibels above SRT. Right. So this SDS, the PB max in SDS, the PB max is approximately 100% at near 40 decibels above the SRT. Right? Okay. If there is a conductive hearing loss, the patient can still achieve PB max of 100. He can still identify all the phonetically balanced word correctly, but the sound required is more. Okay, so the PB max score in conductive hearing loss shift towards right, but patient is still able to understand and correctly identify all the words. Now, what happens in a sensory hearing loss? In a cochlear hearing loss, patient is never able to identify all the words correctly. Patient is never able to identify all the words correctly. Okay, so the PB max is never 100%. Right? There is a plateau. There is a plateau, never goes above that. Now, in case of retrocochlear hearing loss, if we keep on increasing the intensity of sound, there is a rollover phenomena. That means we are increasing the intensity, and what happens? There is a rollover phenomena. The rollover phenomena means now the phonetically balanced word, the PB max score, it goes down. Okay, so if we increase the intensity further after a peak, the PB max score goes down. This is known as rollover phenomena. This is seen in retrocochlear hearing loss. Okay, so speech audiometry can be used to differentiate between cochlear and retrocochlear hearing loss. All right, so let's come to the next test. The next test is tone decay test. So what is this tone decay test? The tone decay test says that if we give a sound, this sound is given to a person, to a normal individual, okay, at his hearing threshold or within 5 decibels of his hearing threshold, he should be able to hear that sound for at least 60 seconds. So if a normal individual is given sound at the hearing threshold or within 5 decibels of his hearing threshold, he should be able to hear that sound for at least 60 seconds. But in case of sensory hearing loss, he is not able to. It decays earlier. So what we do is, we keep on increasing the threshold, we keep on increasing the intensity of sound from the threshold, okay, and we check at how much intensity increase, the patient is able to hear the sound for at least 60 seconds. The tone decay, it decays after 60 seconds. Okay, so what we see over here, in case of retrocochlear hearing loss, the sound intensity has to be increased more than 25 decibels above the hearing threshold. Okay, this to hear the sound for 60 seconds. Right? So this tone decay test again identifies your retrocochlear hearing loss, whether the hearing loss is cochlear or retrocochlear hearing loss. So speech audiometry and tone decay both help us in identifying the retrocochlear hearing loss. These are both tests of retrocochlear hearing loss. Okay, now let's come to some cochlear hearing loss. some cochlear hearing loss tests. So cochlear hearing loss tests, they are based upon a phenomena. This phenomena is known as recruitment. This phenomena is known as recruitment. In every cochlear hearing loss, there is a recruitment. So what is this recruitment? The recruitment is that the sound that is given appears louder than it is actually. Okay, the sound is appearing louder than it actually is. So that is a phenomena of recruitment, and this recruitment is particularly for cochlear hearing loss. Okay, so let's look at this phenomena. So number one, we have the ABLB lettergram. So what we see over here, this is a normal ear and this is the affected ear. Okay, so what we see, a sound which is heard in the affected ear, you see this here the patient is able to hear at around 0. This is the hearing threshold, and what we see over here, you have to increase the sound by approximately 45 decibel so that the patient is able to hear like a normal person. Right? Now after what happens? You increase the sound by another 5 to 10 decibels. He is hearing like the other ear at 30 decibels. So he is hearing like a person who is hearing at 30 decibels. Okay. So now you see, you increase the sound by another 10 decibels and he is hearing equivalent to what he is hearing when the sound is increased by 50 decibels. Right? Now you see, you increase the sound by another few 10 decibels or so, 10-15 decibels, and he is hearing as equivalent to what the other ear is hearing by increasing the sound by 70 decibels. Right? So you see, from here 40 decibels, from 40 decibels, 45 decibels, you have increased the sound only by 30 decibels. You have increased the sound only by 30 decibels. But the perception of sound, you see the other side is a comparison. So the perception of sound that the person is feeling that the sound has increased by approximately 70 decibels. Right? So the perception of sound is, you have increased sound only by 30 decibels, but the perception has increased by around 70 decibels. Okay, so now you see over here, next one, you see the both sides are balanced. So you see this patient has approximately 45 decibels loss. Here the patient has a 45 decibel loss. Okay, but now when you have increased the sound to 90 decibels, okay, you have increased over here only 45 decibels, but the perception of sound has doubled. Almost 90 decibel increase in sound the patient is feeling. Okay, this is known as ABLB lettergram. Okay, this is ABLB lettergram. It identifies the patient is having a cochlear hearing. That means the patient is having cochlear hearing loss. Right? Another test for cochlear hearing loss is short increment sensitivity index, CC. Short increment sensitivity index. So what is this short increment sensitivity index? The patient is given 1 decibel increasing clicks above the 20 decibels of his hearing threshold. So above 20 decibels of his hearing threshold, this is the threshold. Okay, the patient is given clicks. Patient is given clicks. Okay, 1 decibel increase in sound. So patient is seen how many clicks he is able to identify. How many clicks he is able to identify. So he is able to identify these clicks if the patient is having cochlear hearing. Patient is able to identify these small decibel changes in sound when the patient is having cochlear hearing loss. So again, CC test is a test for cochlear hearing loss. Alright, so this question, we have to remember this table, the cochlear versus the retrocochlear hearing loss. So as I have told you, speech audiometry, it helps us in identifying the retrocochlear hearing loss. Number one, it is the PB max score is never able to go above 40, generally less than 40%, and there is a rollover phenomena in the retrocochlear hearing loss. Okay, number two, we have seen the tone decay test. In tone decay test, in retrocochlear hearing loss, we require a tone of more than 25 decibels so that the patient is able to hear at least for 60 seconds. CC test, I have told you, that is seen in cochlear hearing loss, and there is a positive recruitment. A recruitment is present. Okay, sorry, all right. So we come to the cochlear versus retrocochlear hearing loss. This table is very important for us. This table is the one that is asked in the exam. So as we have discussed the speech audiometry, so what we see is that in retrocochlear hearing loss, the speech discrimination score, the PB max score, is always less than 40%. Okay, and there is a rollover phenomena. I've already told you rollover phenomena helps us identifying the retrocochlear hearing. Now, in the tone decay test, we see that in retrocochlear hearing loss, the tone decay, we have to give sound more than 45 decibel, the hearing threshold, so that the sound is heard for at least 60 seconds. So that is the tone decay test. Okay, now the CC score, the CC test. So the CC score is positive in cochlear hearing loss. I have again told you CC and the ABLB electrogram, both are tests of cochlear hearing loss. And in CC, the score, the patient is able to identify 70% or more clicks. So whenever we increase the sound by 1 decibel, the patient is able to identify 70% or more of these changes when the patient is having cochlear hearing loss. So this is your CC score, and we come to the ABLB lettergram. So I have told you the ABLB lettergram. You see, we increase the sound by less, the perception of sound is increased more. So you see, this is a converging graph. This is a converging graph. The affected side, if you've seen, we started at a 45 decibel, the normal side we started at a 0, and then both of them, they have come equal to each other. So we have a converging graph in ABLB lettergram. Both these tests, CC and ABLB lettergram, both these tests, these are the test of recruitment, and recruitment is positive in cochlear hearing loss. Okay, Bera test we have already discussed in the physiology of hearing, and we know that if wave 5 is delayed or it is absent with wave 1 present, so wave 1 is present, 5 is absent, or 5 is delayed, that means patient is having retrocochlear hearing. That means the patient is having retrocochlear hearing loss. So this table is very important. It helps us in identifying cochlear and retrocochlear hearing loss, and this is many times asked in the exam. Right. Okay. So that finishes our tests of hearing.